morning, everybody. Welcome to Pediatric Grand Rounds. As you can tell, we are virtual by WebEx today, but the usual reminders for those of you who can hear my voice, make sure that you are muted. And if you have questions for our speaker or comments or anything, use the chat with everyone box and I will read them off at the end of the presentation. And I'll turn things over to Dr. Hingarani, who's going to introduce our lecture and our speaker for today.
Thank you. It gives me great pleasure to welcome back Dr. Luan Parek to Seattle Children's for Grand Rounds and for Fellow in Residence Research Day tomorrow. Dr. Parek is Vice President of Academics, Women's College Hospital, and a staff nephrologist at Women's College Hospital and Hospital for Sick Children. She's a professor of pediatrics and medicine in the Departments of Medicine, Pediatrics, Epidemiology and Health Policy, and Management Evaluation at the University of Toronto. She did her residency and fellowship in MedPeds. She also did her fellowship in pediatric nephrology and adult medicine nephrology at the University of Michigan. She earned an MS in biostatistics and study design. She did a postdoc at Johns Hopkins in 2000 and then joined the faculty there. 8 years later, she returned to her native Canada and accepted a faculty position at the University of Toronto and a scientist position within Sick Kids Research Institute and now Women's College Hospital. She's a clinician scientist and an international leader in clinical epidemiology and translational research in kidney disease. She's revealed novel genetic risk factors leading to kidney disease and increased risk of cardiovascular morbidity and mortality for children and adults living with kidney disease. She's published extensively and has mentored over 80 postdoctoral candidates to become the future clinician physician scientists moving the field forward. She has received several awards and most recently was selected as the Barbara T. Murphy Award recipient for a Lifetime Achievement Award from the American Society of Nephrology. She's been elected into many academic honor societies, such as the American Society of Clinical Investigation, the Association of American Physicians, the Pediatric Academic Society, and the American Pediatric Society. Above all, she is a wonderful friend and colleague, and I can't wait to hear what she has to teach us today. Thank you.
Thanks so much, and thank you so much for inviting me. I'm going to give my disclosures, and just to say that I'm going to use one slide from Vertex, which will become evident throughout the talk. Today, I'm hoping to really talk to you about how we build evidence for children with nephrotic syndrome. And really, the idea is that how can we do better with what we're currently managing with our patients? And childhood nephrotic syndrome is really important, I think, because a lot of general pediatricians, just in Seattle, are actually managing childhood nephrotic syndrome and need to manage it well before you have a pediatrician. And there are many people who practice in places where there aren't pediatric nephrologists to refer them to. I actually took this picture from a tabloid, which actually highlighted how important nephrotic syndrome is. A family actually was doing a GoFundMe page, and they got picked up by a tabloid in the UK, Alexis Khan, and they wrote about her having nephrotic syndrome and then getting treated with steroids. And what's interesting is, we think our goal is really just to get them into remission because it's a waxing and waning disease. But I think our goal should be earlier diagnosis and how can we prevent it? Complete remission, and can we do complete remission for life, which I think is really important to consider, especially in pediatrics. We want to have no adverse events or side effects from medication. And we'd like to think about targeted therapy to prevent progression to chronic kidney disease. And as you can see here, they highlight Alexis as having all these mood swings, and she clearly looks miserable here and is in the hospital. And our goal is really not just to get them out of the hospital, but actually to prevent the disease progressing. So how are we going to do that in childhood nephrotic syndrome? And there's a lot that we still don't know. But what we typically think about is traditional medicine, where we do a one-size-fits-all approach. But there's also this idea of stratified medicine, where we start taking subgroup populations that are at higher risk, and maybe we can understand why they're at higher risk, understand if they're biomarkers or molecular phenotyping that we could do, and could they benefit from different types of therapy? And then how do we put that all together with understanding all the omics, lifestyle, health history? How can we put it all together so that when a patient first presents to us, we can actually give them individualized therapy directed to them, potentially for the genetic risk, potentially for circulating factors, and not try to just do the one size fits all. But lots of pediatrics have no data, in that we actually have really relied primarily on a lot of expert opinion. And there are multiple factors that impact evidence generation for clinical care, things that are clearly out of our control. And that's all that stuff that's on the right. Part of it is, as an investigator, It's extremely difficult to get funding for multi-center studies as a junior investigator. Funding agencies often don't fund pediatric studies. Regulatory agencies are putting things into place to make sure pediatrics is included. So there are some levers, but there's a lot of things that are sort of out of our control. But the stuff that's sort of on the left-hand side, which I think is important too, is that people really feel reticent to do trials in pediatrics. And what I think is that we need to really think about why is that, and can we actually change the culture? We also need to think about what are all the factors that I think are really important for childhood. But as children age, we also have to say that we're getting them ready for adult health and adult disease, and that we want to make sure we manage them well so that then when they transition, we know that they're going to go on and do well for the rest of their lives. So I think as pediatricians, we really think about prevention, and because we really want to have them prevented getting disease, but also getting all those other comorbidities related to our treatments. So there's a lot of work that we need to do in general in pediatrics, I think, to help move the field forward for all children, not just for nephrotic syndrome. And so this is a typical sort of triangle showing that you've got background information, expert opinion, where I think a lot of pediatrics sits. We're moving things out from case series to case control studies. And ultimately, the goal is good randomized controlled clinical trials. With that, you can ultimately do systematic reviews and meta-analysis and then generalize it to the various populations and understand what are the barriers or limitations. But we're still kind of here. And I think what I want to go over today is why we're still here, but also show you where this is helpful, but how we can continue to push forward so that we can get better evidence in order to maximize what we do for our patients. So just to let you know that, what is nephrotic syndrome? So just for those, and for the residents or trainees who are here, just remember that this is a podocyte that sits on top of a vessel within the kidney itself. You have red blood cells that are going through it here, and then it creates this interdigitated space that's linked to the basement membrane. And what's really important about that is that podocyte, if you have multiple genetic abnormalities within these different parts of the podocyte cell body or the arms or the slit diaphragm, that's associated with genetic forms of nephrotic syndrome. But if you don't have any of those genes, then you have childhood nephrotic syndrome. We still don't know the cause. But what's important is that you get this complete effacement that happens when they get disease. And when you get the complete effacement, that interdigitation of the slit diaphragm sort of goes away, and it forms these holes in order for you to be able to filter blood and protein within the urine. And ultimately, we give steroids because we know it has an effect, and it sort of closes that and improves that podocyte effacement so the podocytes are healthy. However, we don't know actually what triggers the whole disease. So even though we've known about nephrotic syndrome and it's been described since the early 1900s, the actual cause that's not genetic is not known. But there was an observation done in 1957 that this is an example, again, of a simple case series, but it completely changed how we managed our patients. And that 60 years ago, the use of steroids actually completely transformed what used to be a disease that resulted in excessive mortality and significant morbidity, now is actually resulting in that patients were actually able to be better and didn't die from the underlying disease. And what we also know from the epidemiology, because that's always important, is that it's a rare disease in childhood, but it is one of the most common kidney disease that we see worldwide, but also that general pediatricians manage globally a large amount of this in many countries, especially low-income countries. And the incidence cases vary by country and region. And what was interesting in Toronto was that it actually doubled in number over 10 years, and it continues to increase as we have a larger South Asian population coming in. So there are clearly differences globally from Asia and Africa. And what we need to understand is sort of what are those differences that result in this difference or incidence of nephrotic syndrome. We also know that if you take a look at steroid sensitive or steroid resistant, that also differs regionally. And again, with simple epidemiology, we're able to say what are those differences. But what we're doing here is really just dichotomizing the disease into sensitive and resistant. And what I think we do is we take steroids and we say, well, what's our one size fits all? So we give everyone the same sort of initial starting dose, and then we try to see who's going to benefit or not benefit, or who could have an adverse event because they require higher doses. And so for the benefit and no benefit, I think what's important is that there've been lots of trials, and I'm not going to go over this. I purposely left it there to look busy, is because there are lots of trials that people have taken a look at to try and tweak what should we be doing in terms of the 6 weeks and 6 weeks, and how much should we be giving, and how fast should we be doing the tapers. And people were quite concerned about tapers. So what's happened is that people were giving longer courses, and early studies showed a potential benefit, but now a recent RCT in fact showed no benefit of greater than 2 to 3 months of therapy. And this was not being published yet, but this was an abstract from a number of years ago where someone actually took all the studies to take a look and say, what's the total duration? And in fact, it's really been shown now in clinical trials, in a number of clinical trials, that steroids at a shorter duration have similar time to remission and actually do quite well. And so I think we've kind of solved this one issue, and I don't think we really need to think about doing more related to that. But what we need to understand is that as patients are steroid sensitive, steroid resistant, it's important to recognize that depending on your population, about 10% are steroid resistant, but some of those are still treatment sensitive. So there's only a small number that we're really concerned about. But when people go over to steroid sensitive, what's important to recognize is that the majority of cases are still managed by general pediatricians, depending on where you are regionally and different jurisdictions, where 25% will never relapse again, 40% will have infrequent relapses, and depending on how close those relapses are, they may actually get treated differently. And only about 35% are often referred to the pediatric nephrologist, where we now really need to decide how to manage them and how to decide about steroid-sparing agents. And so this is really the area where there's still no consensus on steroid-sparing agents, and we need to understand how can we do this a little bit better. So a few years ago, we actually did a review for Lancet, a seminar in nephrotic syndrome, and we came up with this algorithm that was based on data that was available and economic data that was available, but also information that was available in terms of practice. And we thought that we'd come up with this flow diagram of the people who are now getting different steroid-sensitive, steroid-sparing agents. What's really interesting, though, was we got a lot of pushback from the reviewers because many people felt that you should go straight to rituximab, a biologic. Other people felt that you should skip cyclophosphamide altogether, and they have in many places. Other people don't get levamisole because it's no longer available in North America, for example. And some places like Europe use mycophenolate mofetil almost primarily. And so what was interesting was, as we gave our review, we tried to show that there was a lack of data to actually support every single one of these stages because we haven't been systematic in sort of generating data. And even though we look at a trial might show rituximab versus steroids, but rarely do we compare all those steroid-sparing agents. And so I think we've got clinical equipoise, but there are people who I would say are therapeutic activists or nihilists. And I think in general in pediatrics, we are concerned about not doing anything. And so unlike in the adults where they might be willing to give a placebo, we're uncomfortable doing that. We also want to make sure that we're giving the child the best opportunity to have their underlying disease treated. So what we really need to think about is doing proper comparative effectiveness studies where you compare drug A and drug B that you think are potentially equally effective, but you need to be able to study them and compare them. And if you take a look, though, what's interesting, if you take a look by region, and it's never been done in the US because I think it's actually quite complicated to do, but if you take a look at the practice choices that have happened in different countries, and in the light blue here is the tacrolimus or cyclosporin, the calcineurin inhibitors, and you can see that by different countries it varies quite a lot. We use cyclophosphamide quite a bit, as well as Africa, and also same with Europe, here in the sort of green. Rituximab, though, is used a lot more in Europe and in Canada than it is in Africa, not surprisingly. Interestingly, it's not approved for use completely in Japan, even though that's where a lot of the trials are happening. And so what's very interesting is we are limited by both our government legislation on how drugs are approved, as well as by physician preference. So it isn't just physician preference alone, and it's also where physicians actually train. And so when we did a systematic review in Africa, it was evident that where the African investigators had trained really depended on what drug of choice they used. So Is it bad to just use case series? No, it's not bad. That's how we started using steroids, and then we went on to a number of clinical trials. What's interesting is the first report in 1992, cyclosporin, being used in nephrotic syndrome, particularly in those who had FSGS. What was interesting was, since that report in 92, was that a number of people started using it, and we globally started using it. And at every center that I was at, or that I went to, really based everything they did based on this original case series that was done in 92. And since then, we've only had one or two clinical trials, actually one clinical trial with a calcineurin inhibitor, and we've never had any others. So we've based everything that we do globally on an off-label use in nephrotic syndrome based on really this initial study. And even though I think it was transformative in what we do, my argument to people is, well, we still don't know head to head what's the best drug that we should be using. And so minimal pediatric data overall for steroid-sparing agents. Often they're underpowered and they're poor quality. We have high variable treatment response rates to explain population differences. And there's no validated sort of prognostic markers that we could use to help improve that between studies. And so these are the only two studies that happened, a total of 45 and 50 patients. So in total of 95 patients globally, we're still using calcineurins because of their benefit over alkylating agents. But we think that that's sort of, it's in comparison, it seems like there's a 10% benefit, but it's not really clear because in fact it crosses one. So we need to really understand what's the outcome related to that. And then if you take a look at, sorry, it was the different study. If you then go to the next slide, what was interesting was when we come up with guidelines, none of the guidelines actually have any evidence for us to depend on what we're going to do for steroid-sparing agents. And so it's really trying to understand what we can do. And what they're proposing, what would be ultimately an ideal study, would be a multi-arm, adaptive, platform, randomized controlled trial, where we would recruit almost everybody in North America to be able to be on something like that. But that's almost impossible for us to do. And part of the reason it's impossible is that there are lots of barriers to conducting RCTs. And I'll go over some of them a little bit. But the other thing that's quite sad is that less than 60% of pediatric RCTs are ever published. And that's often because we can't recruit into the trial itself. And that's a really important thing. A simple trial that's currently being done in chronic kidney disease that Dr. Joseph Flynn and I are on the DSMB. Interestingly, a lot of it is related to recruitment. And it is surprising and it's sad that we can't recruit into a relatively simple study. And it's important that we all recognize that actually conducting RCTs are really important. And if we do, we're able to get more of them published, we can actually do more of them to provide evidence for our patients. And so if you look here, this is an adult RCT rate over time, and that's going sort of exponentially. But pediatric trials have been relatively static. And I think this number is really quite surprising. And I'll say that when I was at Sick Kids as the Associate Chief of Clinical Research, this was completely consistent with what we found, was that trials didn't get completed. So the issue is that a traditional RCT is not really feasible, I think, to do this multi-arm trial. We would need at least 400 patients to detect a 15% difference in 2 years. And it would take us 5 years to do the recruitment. We also know that it takes 5 to 10 years for traditional RCT, and novel drugs are being developed all the time. And how are we going to do this kind of trial design in 5 to 10 years? There's a huge amount of cost for it. Some of these trials on the adult side cost $80 to $90 million to run. And so we don't have infrastructure across pediatric nephrology. And there is also this ingrained belief that what we're doing is the best protocol. So there is a way for us to use observational data, and that we can build these collaborative studies, of which Seattle is a leading member in a number of them, where you can do these large sample sizes and take a look at it. You need longitudinal follow-up that's quite long so that you can truly make sure that there's a real outcome, and we're not just assessing short-term outcomes that may not have any implications down the road. Beneficial to us is that children do really well. And so unlike the adult studies where mortality tends to be the most common factor that they take a look at for hypertension and for heart disease, we have really good survival. And so what we need to think about are surrogate outcomes and what are the things that we think are really important. And so we want to be able to do comparative effectiveness, and how can we do that? So I started when I moved back to Canada, the INSIGHT study, so that we can start developing in our large population an understanding, almost like a learning health system, of what could we do using the data that we have and the patients that we're seeing in order to make sure that we're able to address some of these questions. And this is just some of the work that we've done, which I will not be going over. But what I wanted to go over was, this is sort of how we do our regimen. So we've recruited well over 750 now, but data on 600. 600 are treated with steroids. The majority of them, actually, a very small number, get other agents right away. The majority of them will get cyclophosphamide, then they get tacrolimus, then they get Nephrotic, and then they get rituximab. And so we felt that this was a relatively conservative process, that we cycle kids through it. And you can see that out of our 600, only about 34 ended up getting rituximab. It's higher now, clearly, because our sample size has gone up, but it's a relatively small percentage of our total population. Now, how can we compare across those 4 drugs? So when we took a look at the observational data, we said, well, let's actually take a look and see, because what does it look like 5 years out? And what you can see, in fact, is that they all have about a 25% incidence of failing. And so it almost didn't matter what drug you looked at. But if you looked at each individual line, and clearly this defies any log rank comparison, so I don't want you to think about that. But if you take a look at rituximab, we know that those who took rituximab, actually almost all, 100% relapse before a year. When you take a look at mycophenolate, which was also a smaller number, that they seem to do okay initially, and then they would relapse later on. When we take a look at tacrolimus in red, they're typically on the drug for 2 years, and then we wean off the drug at 2 years, and you can see a whole bunch of people relapsed after 2 years, so not surprising. And cyclophosphamide, where the drug is given for 3 months, you could see that there was a pretty steady course throughout, and in fact, over about 50% at a year did well with no relapses, and then had relapses further out. And so in a 5-year study, you think, the drugs are pretty much the same, or maybe there's a difference. And because we had 2 small groups in mycophenolate rituximab, we didn't take a look at that. We just looked at cyclophosphamide and tacrolimus. And what we did was what we call a target trial emulation, which is another alternative causal inference. And you can do causal inference or infer causality definitely in a randomized trial with an intervention. And so you're going to give an intervention and you're going to infer that there was a benefit because you know that you gave that medication and you're able to follow them prospectively over time. Well, the question was, can you now actually emulate a trial and do a target trial? But what you're going to do is emulate that using observational data. And what's good about that is that it addresses a lot of the confounding issues and it's much more generalizable. And so what you do is you actually take the data that you have and you say, how can we use it just like a trial? And so these are the things that you do. So in a retrospective cohort study, patients get enrolled in a baseline of eligibility. They have treatment assignment that can be at any time, and then you're doing their outcome assessment over time. In a target trial emulation, what's different is you basically say, at this time point, you have a higher propensity to get drug A versus drug B, or maybe no drug. But in our comparison, we're going to do drug A and drug B. And then we're going to see at time 0, when the drug starts, what happens afterwards. And then when we take the population at that time, we'll basically assess what's your propensity for getting drug A versus drug B. And what's good about that is that we're now balancing the study population, mimicking a randomization, but it's not randomized. And then we're trying to actually understand then the treatment assignment and who's getting drug A and who's getting drug B. And then we have a similar time 0. And so in a randomized controlled trial, you have the same baseline eligibility. You come in, you're going to get a treatment assignment, you get randomized. Now you've got drug A. The difference, though, is your outcome assessment happens often based on the trial design, and it may not have as long as a follow-up as you might want based on the trial design. So we actually simulated, using our observational data from INSIGHT, what did we actually have in our population in terms of our aim, our eligibility, our treatment strategies. And the only thing that we do differently is, instead of randomization, we basically take the population, we say, what's the propensity for you to get drug A versus drug B? And then we adjust by a whole load of factors to understand what are those factors that lead to a person actually getting a drug. And it could be physician, it could be center, it could be clinical characteristics. We include all of that in the model. And then what we do is we also set time 0 as the drug initiation date. And instead of an intention to treatment effect, we basically do a modified intention to treat analysis, with the idea is that the drug started at that same time. And then what we do is we actually do in fact include a control, but our control may actually have nothing to do with the disease. We just want to make sure it doesn't differ between the two groups to make sure that they're balanced. And sometimes in cohort studies, you have what we call informative missingness. So we assess missingness, and we just want to make sure that it's balanced between the two groups. So by doing this target trial emulation, when we took a look, let's say on the left-hand side, this is similar to the figure I showed you before, in comparing cyclophosphamide in blue to calcineurin inhibitor. So this is prior to propensity score weighting. It so basically means I took everybody who was on a drug and I'm not comparing them. And what's important to note is that this is what all the observational studies do when you compare two drugs. And even if you set the time 0, you're not balancing the population. So it basically says, how is that working? And if you took this at face value, I would say cyclophosphamide is actually a better drug than calcineurin inhibitors, where more of them are definitely in remission. And that if I looked at it before 2 years, I might have a false positive where, in fact, calcineurin inhibitors look better. But when I effectively emulate the randomization by the propensity score and balance my population and say, okay, they're now equal in their clinical characteristics, are now equal in the groups and the propensity for getting a drug. As you can see, there's actually no difference between cyclophosphamide and calcineurin inhibitor. And this is really important because we're looking at 5-year outcomes. We're interested in complete remission. We're not interested in just decreasing a relapse, but actually getting them to a cure. And there's actually no difference in how we treat them. And so I think what was important to me was, I think that you can feel good about if you needed to, if you lived in an area that you had to give cyclophosphamide, if you had only 3 months of a drug that you could give them something at a low income country, and that you could potentially use cyclophosphamide and use it in 3 months. And we could now have shared decision-making with physicians, children, and families, because if you give tacrolimus, you're actually monitoring drug, you're doing therapeutic drug monitoring, you're taking a drug twice a day, we give it for 2 years. If you take the cyclophosphamide, you're taking it for 3 months, you're doing blood work on a regular basis during those 3 months, then afterwards you stop and you wean off your steroids. And so this is a time where we can start doing shared decision-making, and then we can also start asking or answering questions also about risk and why people might choose one drug over another related to risk. And we can start doing comparisons of risk overall to now start making proper decisions as we move forward. And I think globally, what will be important is that many pediatricians, especially in low-income countries, may feel more comfortable giving cyclophosphamide and giving it as a 3-month treatment on a daily dose without necessarily needing to do any therapeutic drug monitoring. In Africa, they can't do any tacrolimus levels. And so what happens is that unless your creatinine goes up, they don't make any adjustments in the TAC level. So we could actually be putting a lot of kids into kidney failure without being able to manage medications appropriately. And just to show the subgroup analysis, because you could say to me, oh, but it's going to be different, in different populations. In fact, it made no difference whatsoever, whether you were younger or older, European or South Asian. Even we looked at whether you were at Sick Kids versus some of the other sites, and it really made no difference at all. So then people will say to me, and I've had people come up to me and saying, cyclophosphamide's an old drug, and you shouldn't use it anymore, you should go straight to rituximab. Well, the argument or the discussion I'd like to have with people is, in the inflammatory bowel disease group, they are trying to understand all the cancer-related risk that's gone up over time, and the risk of lymphoma and the risk of skin cancer that's gone up in those treated with anti-TNFs. And so what is our risk of giving rituximab? And maybe we don't know enough about it yet in order to feel comfortable, whereas we have been giving cyclophosphamide for almost 50 years. And so the question is, should we move to a more advanced drug that may have a pathway mechanism, and absolutely children will respond to it? Or should we actually think about how we dose it so that we don't do what IBD did, which is they move forward, they have people on it, and now they're trying to figure out who do they withdraw and take off of it. And so one of the things that I also thought was interesting is that every rituximab study, just like what we've shown here in all the different colors, have actually had different responses and different curves, which shows you that these relatively small studies are not highly generalizable. And so they're quite limited based on either trial design, the population that they're in, or exactly the protocol that they were on. And so again, this is these studies are quite different, and this is our study here in Toronto. We now have more, but our curve looks almost exactly the same. And part of it is the selection bias, part of it is the protocol, and also the region. So how can we do this a little bit better? Because in fact, rituximab is being used now a lot more. So we were actually collaborated with CureGN and Cal Robinson, my fellow, who received a grant from CureGN, and we looked at the data for all children and adults who had biopsied with minimal change disease or FSGS. And what we took a look at was basically how did you respond in rituximab in the blue versus a calcineurin inhibitor in red. And interestingly, there was absolutely no difference from the time the medication was started until follow-up. Now, this is a highly selected population that have been biased because this is a group that are recruited in the study only after kidney biopsy. But you can see, in fact, that there was no significant difference. And so again, we are all really stressed about which agent should we use, what agent does one institution use, does another institution, and I think it really doesn't matter. And what we need to figure out is what can we decide with patients and what would be the safest way to use these drugs as we move forward. So what's happened now is that there's this case series of a B-cell targeted therapy. And in fact, we wrote an editorial on it because, again, we're back to a case series. And what I would argue in pediatrics is rather than do these case series now, we know how to build observational studies. We know how to collect similar information on patients. And we should try and do that and do it internationally so that either we're going to plan a target trial emulation or we're going to go to a clinical trial. But we really need to start standardizing how we're measuring things, because what happened here was 41 children, again, were observed. It was studied retrospectively, but it could have been done much better. And what we wrote in our editorial was that even though it's promising, I think what we're worried about is widespread use again of using this drug. And I heard about somebody getting it yesterday, again, using it based on a case series. And so we need to keep moving forward. And the only way we can do that is if we really start not doing these kind of studies, but really start thinking about trial emulation, standardizing how we collect data, and we're thinking about a platform trial and sort of moving forward. So my hope is we can edit this figure. We'll wait till the papers are published, but hopefully ultimately sort of say that there's really no data to say one is more superior than the other. And so let's actually make it a decision based on shared decision-making with patients. So I hope I showed you that, using target trials, there are sort of robust techniques, that it's actually better and hopefully more generalizable. And remember, though, there's still times for randomized controlled trials, especially for novel targeted therapy, just as the one I was showing you. But we need to work together in order to move that. And I think children deserve to have more evidence-based data to support the ongoing care and our key questions so that we can make sure that they, can live a really happy life without disease. I'm going to go on to something else now to just say, what else do you need to figure out? So we talked here on the left about, one size fits all. But I'm also interested in how can we take those populations and can we stratify them to say, well, actually, there's some groups that still don't benefit. Well, why don't they benefit? And what groups do benefit, maybe even more so? And then ultimately, can we get to precision care? And so what happens with kidney disease is that we have this inevitability, or we're concerned about these people sort of always progressing and progressing rapidly. Just like that girl that I showed you in the picture at the beginning, is that rapid progression. And we know that it happens within years within children. And it's important for us to think about that in those who have nephrotic syndrome or FSGS or a collapsing variant of nephrotic syndrome where they might progress really rapidly. And what we need to think about, again, are these well-characterized epidemiological studies where we categorize people in groups, but with intent, so we understand what we're thinking about. And we also think about social determinants of health. And so this is an old study that was done by Ramuzzi et al. In Italy that showed that FSGS, which is a form of nephrotic syndrome, actually progresses the fastest. And in children, this is actually, in children who are treatment resistant, this is also true. So I'm going to tell you a quick story about a gene and then why we've gotten to precision trials. So in the US, it's been noted that among adults, and this is true a little bit among children, is that the adjusted US end-stage renal disease prevalence, stratified by race, actually shows that those who are African American have at least a 4 times greater risk. But it's getting better over time, which is great, but it's still 3 times greater than those of European ancestry. And it's also higher in the Native Americans and the Asians. In a clinical trial among African Americans in the study of kidney disease, they were treated with a blood pressure medication and given intensive blood pressure control. But what's really important is, regardless of whether you're in the standard blood pressure or the intensive, and whether you were in the trial phase or ongoing, there was this relentless progression, whereas almost 50% of the whole population studied actually had progressed to either end-stage kidney disease or died with kidney disease. And this is despite adequate blood pressure therapy. So there's clearly something else that triggers this population to go on and have kidney disease progression. And the other thing is that colleagues of mine at Hopkins had shown that there's clustering of kidney disease in families with nephrotic syndrome, with FSGS. We definitely see it with both among children. We also see it under IgA or end-stage renal disease. And if you ask families if they have a family history of end-stage renal disease, somebody who's on dialysis or transplant, you'll find that overall it's a twofold greater risk of having end-stage, but it's 5-fold among those who are African American. So there's clearly something about, in the African American population, there's something about the heritability that's interesting, and exactly what is that? So terms that are being used to describe that heritability are really describing the ancestry and the genes in the genome. But sometimes I will be using terms of self-ascribed ethnicity, but I want you to understand that I am using an old data term because part of these populations were recruited in the 1990s, and so that's how they were described at that point. But what I am really referring to is the self-ascribed ancestry in order to understand these genetic variations. And so why study genetics? Again, if we can get to that stratified medicine where we're going to think about these subgroups who are at greater risk, it's just important that we remind ourselves that there's absolutely no difference among all of us, that we share our genome 99%. And what we are doing is we're taking a look at the small, different little bit of variation that might occur among all of us. In 2000, when I worked closely with Linda Cow, what we did was, our hypothesis was the incidence in Baltimore at the time was very high of end-stage renal disease, and that the hypothesis was that there was a gene on the African genome, and because there was admixture over time, that then we would be able to take a look at the admixture mapping to be able to tag the African genome to be able to identify if there was a gene. This is now outdated because now you can do millions of SNPs, but back in 2007, 2008, that this was quite novel. And so the hypothesis was you have an African genome, 2 European chromosomes, and then over time you have this admixture. And the black line is where you have evidence of a variant. And this variant then gets passed from generation to generation. And ultimately then you have a population that you're studying that may or may not have the variant, but it has evidence of an African genome in yellow and a European genome in blue. And what we did was we described the gene called MYH9 associated with kidney disease in 2008 on the chromosome 22 locus. And what you can see here on the graph was that as you take a look at the scattering, whatever was black was the African genome, whatever was gray was the European genome. And you can see that on chromosome 22, there's a large spike, and that showed us that this chromosomal region was actually very important related to the African genome for kidney disease. And in particular, it's ended up being APOL1 and MYH9. And so we identified MYH9 purely because it was known for Mendelian disease, but data came out after our publication from 2008 to 2010, showing that somebody actually, APOL1 was related to trypanosomal infection. And so Martin Pollack then took a look at APOL1 and was then able to show that it was likely the variants in APOL1 rather than MYH9 that were associated with kidney disease. So APOL1 variants are associated with chronic kidney disease risk. You have to have, it's inherited as a recessive, where you have to carry 2 variants from 2 haplotypes. And it's important to recognize the reason that region is so important is because it's related to lipoprotein metabolism. And specifically, APOL1 is bound to HDL3, and it actually circulates. Again, it's not a gene that's highly conserved across all animal species. It's really in humans and some non-human primates. And so we think that it's related to some infection protection, specifically the data that showed it was related to African trypanosomiasis. And so if you carry no risk alleles, you get sleeping sickness. If you get one risk allele, you don't get sleeping sickness. If you get two risk alleles, you don't get sleeping sickness, but then you get chronic kidney disease. And so the question was this a variant that occurred 60, 70,000 years ago related to sleeping sickness? And then that's why we have this increased risk in West African genome. Well, it's really complicated, and I'm not going to go over it in too much detail, but to tell you that if we compare to sickle cell disease, where you also inherited autosomal recessively, but it has complete penetrance, we know that rarely at risk, but you can get sickle cell trait that puts you at risk for disease. You can have two variants that definitely gives you disease. It infers protection against malaria, and it's relatively not rare, but it's 1 in 300 to 500, and it's uncommon among European Americans. APOL1, on the other hand, is not an acute crisis, but this progressive indolent disease. Its penetrance is variable, and so not everybody who's a carrier actually will get disease. And it's important to recognize that it infers protection against sleeping sickness, but sleeping sickness varies across the continent, which will be important soon to understand. And so maybe there's other mechanisms that it's involved with. And 1 in 10 to 1 in 15 African Americans carry it. And so that's a huge number that are carriers, but not everybody gets disease. So there's clearly some gene-environment interaction, and Europeans have it about 4%. So can we actually then take a look at outcomes? So what's interesting is, and I did this summary just to show that, in childhood, it's been shown to be associated if you have a child who's a carrier, their mother's at greater risk of preeclampsia, young children are at greater risk of hypertension. It's related to this form of nephrotic syndrome, protein in the kidney, and also chronic kidney disease. But if you have sickle cell disease, you're at greater risk, or if you have an HIV, you're at greater risk. So there's clearly something related to infection that puts you at greater risk. But based on the studies that have happened, it's really important to understand that when you do a gene discovery, you're purposely skewing the data so that you find something. But once you start taking a look at it in every population, it's likely to have regression to the mean where you don't see as high odds ratio. And definitely when you have it, you're about 2 times greater risk, 1.5 to 2 times greater risk of disease progression over a decade or so. So recognize that it, again, is indolent disease, puts you at risk, but it's a relatively slow decline. So we had the opportunity to understand what was happening within Africa. And so a project led by Kinlulu Ojo, who's dean at Kansas. Before I was at Michigan, we're working with a large number of people, and Rashid Badagason is one of the other pediatric nephrologists. And the question is, what can we learn in Africa that might have some implications globally and also to North America? And what's important is that the African genome has the greatest genetic diversity. Signatures are relatively important to understand, and we think it's related to infection for us. But it also helps us to understand the structure and association differences in APOL1 throughout the whole continent. And so this was done by a group within the H3 Africa Collaborative. But what I really want to show you is just this graph on the left. And to say that these are all our sites here on the left within Africa. These are rare populations that have never been genotyped before and had full genome sequencing. But it's important to recognize that West Africa, Central Africa, and Southern Africa cluster and are a little bit different. But what was interesting, East Africa has the greatest amount of diversity because you can't compare Ethiopia and Kenya, who are right beside each other. Their populations differ quite a lot. And so what's important about all of that is that Africa is not monolithic, and people think of it as it being monolithic when we talk about people from West Africa, or people think about people who've emigrated, but it's not monolithic. And so we need to consider all this genetic variability. We also need to recognize that if you sample different populations, the allele frequency is going to vary. So if I take a look at a cross-section among 10,000 people from all these different countries, my overall allele frequency having 2 risk alleles is only about 5%. But if I do kidney disease, then it actually goes up quite considerably. If I do HIV disease, it goes up quite considerably. and HIV disease here for children in the Democratic Republic of Congo. So it's important to recognize that population differences are there. It's also important to compare that in the US, places are actually higher depending on where that population was from. And so that's important to understand also. And it's important to understand that as we take a look at these studies, everything marked in red is from Africa. You can see that again, there's this regression to the mean. But we have so few longitudinal studies in Africa, it's hard for us to understand progression over time. But we suspect if it's like the US, it'll be over decades. So why is this important, and why am I telling you about this gene? Well, I think it's important because the animal data has been really interesting. They've been able to recapitulate the proteinuria in APOL1G2 haplotype. What's interesting is that the mouse model replicates, I think, like the adults, it's not complete penetrance. And there are conditions that you need to induce abnormal function, such as increased interferon, like an HIV disease, or increased stress, like a sickle cell disease. And what's really interesting is that the way it works for APOL1 in the trypanosome is that it opens a pore, so APOL1 can enter the cell and then can actually kill the trypanosome. So within the cells themselves, this is ubiquitous in all cells, there's an APOL1 channel that occurs. And what happens is that this protein actually forms a pore and causes cell lysis. And so there's something related to actually forming this pore, which is important. And the reason I think it's really important is because there's a clinical trial that was done in 13 patients that was actually published just last year in the New England Journal by the company called Vertex. And Axelpin, I still have trouble saying all these fancy drug names. But what they've done is they actually developed a pore blocker where you actually are able to block the pore, similar to cystic fibrosis. And you're able to actually then reduce the proteinuria quite remarkably, 47% overall. And those who had nephrotic range proteinuria or subnephrotic, about the same amount. And you could see that, in fact, it was sustained over time, which is really exciting. And so what's also exciting was this trial has now been approved for children. So you may start seeing children that potentially could be enrolled. They're taking children in the US from age 10 and up, and everybody greater than 40 kilos. And so I think this is exciting because now we have a precision-directed therapy. We have safety data to show that it's safe, and we know that we can be able to give it to children and potentially be able to target this one specific gene. And there are many other trials that are ongoing, which I think are exciting. And I think the more trials and the more studies that we do to try and identify how could we actually treat those who are carriers who have evidence of kidney disease, especially this type of childhood nephrotic syndrome, I think we can definitely make a difference in their outcome. So who are carriers? So I think I just want to make this point quickly is that we have to remember that those who descended from slaves, there were over 12 million that came to the Americas. And it's important to recognize that based on where the slaves were moved to is actually where the distribution of APOL1 occurs. So all the purple dots highlight the increased incidence of APOL1, and you can see the increased prevalence, and you can see that all the purple dots are within West Africa and within the Caribbean. But again, it's not monolithic. And what's interesting is when you take a look at a certain study that includes children, 400 children with FSGS, you can actually see that people who self-report as white or multiracial are also carriers of APOL1. They just may not know that they have African ancestry, or they could also randomly have it. And so it's really important to recognize that now that we've identified a gene, you don't then start saying we should only take a look at this one population. And what I really think is important is that, and you can see here in Seattle, you guys are up here, that the multiracial population is expanding, and it's quite dramatic now. In Canada, we're at 43%. Our populations are changing. It's not so simple to ask people what their ancestry is, and so we really should be taking a look at doing genetic testing in everyone. And so APOL1 is a gene for progression. I think that because of its variability, we have to understand how to be inclusive about how we do genetic testing. And we have to understand why does it differ in different places and understand how we can do it, how we can study it a little bit more. And what I think is important is that there are these ongoing trials, which I think are so exciting and hopefully option for patients. So my hope is over the next few years that we'll continue to develop this where we get deep phenotyping. We continue to individualize strategies, and our goal is long-term remission. So that first patient I showed you, Alexis, my hope was if she had APOL1, she could get this drug and we could prevent the progression to end-stage kidney disease. So our goal really in medicine should be, we do the one size fits all. We recognize though that there are groups that are different and we need to understand why they're different and what are the things that could explain it that we need to understand. Always also thinking about social determinants of health. And then ultimately, how can we do precision medicine better? So I can't do this without a big team. And so I'd like to really highlight Cal, who's a PhD student with me now, a pediatric nephrology fellow, who did all the work related to target trial emulation, and my team who spends a ton of time recruiting patients, and our pediatric nephrology group here. We have created a ton of knowledge translation available. So if you want infographics, if you want anything, we do newsletters, family events and focus groups. We're up to have 750 patients now. We have infographics in multiple languages. They're also available. Patients have actually approached us to help translate them. And we definitely have it vetted though by somebody who's a native speaker. And but they're available to everybody and you can download them. And these are all the people I've also collaborated with, and we've shown some data here that's still preliminary, but really thanks to everybody who we work with. Thank you. Okay, I'm done. There's silence. Okay.
Ah,
Ah,
finally. Yay.
yes.
Hi. Thank you
There.
so much. I was unmuted and I think it took a minute. Um, Sorry for that awkward silence.
That's all right.
If
That's all
you
right.
are,
I just want to make sure there were people awake. Yeah.
thank you so much. That was wonderful. I was talking, but no one could hear me.
Okay.
If you are in our WebEx audience and you have a question or comment, please feel free to enter it in the chat. I will be watching that. And then Emily Rice is in Right Auditorium where there also are some people. And so if they have questions, she will hand them a microphone so that everyone can hear them. And I know you have a hard stop, so we'll wait a couple more minutes. And then if there are no questions, we can say thank you and let you go. I can let Dr. Hingarani take care of that. Think we're good with questions.
Aaron
Thanks,
Whiteman has
everybody.
a question. There is a question.
Go ahead.
Go ahead,
Hi,
Dr. White.
sorry, I couldn't type fast enough. This was wonderful. Thank you. Um, I I want to ask about a tension that I was that at least I was feeling, or ask you about how you might think about this between the first half and the second half of this really remarkable talk. Um, Particularly, we know that the children who we treat with nephrotic syndrome are, as you demonstrate and have demonstrated, are not a homogeneous population. And we know increasingly that group of children who don't respond to steroids or those who frequently relapse or who progress are similarly not homogeneous populations, whether it is by looking at biopsies or better understanding their genetics. These are or their environmental interactions. These are likely much, much smaller of an already small population. And it would be a good thing to understand where each of our children, or each of the patients sit within that. But it seems that that recognition would undermine the data and the study processes that you've described in the first half of the talk. Because it seems to begin, at least for me, of treating them as kind of a more homogeneous or grouped together. Sorry for rambling.
No, I think you're absolutely right. It is the hard part because there is individualized variability. And what we're trying to do is say, well, if we do a one size fits all approach, let's try and assume that that variability is pretty standard among all those groups. But we know that's not totally true. But what we can do is we can start with that, where we take the groups that are like they never relapse again, or the groups that infrequently relapse. And if we can start taking those characteristics or those molecular markers on those people who have good, like I won't say good disease, but have good markers for like not getting further disease versus those who get worse disease, then ultimately we can start teasing out those differences. My hope is in the trial emulation, my hope is by next year we have a larger population and that we're going to group for multiple studies and we're going to account for their genetics. And then my hope is we can see if that still holds true. And maybe that might account for that individual variability, because we were able to show that and we haven't published it yet, so I haven't shown it here, but from a genetic perspective, we are able to show that there are differences by ethnicity, but there's also differences by whether you are a frequent relapser versus an infrequent relapser. And so my hope is that I can account for some of that by genetics and then do the same trial emulation, take the drug, but say now you're on a drug, but now you also have this genetic variant. And is that going to help me tease out that difference? So I think perfectly valid to say that group may still be too heterogeneous and maybe it's now just balanced heterogeneity from the two groups. And that's why it looks like there's no difference. But maybe as we continue to get further biomarkers, we can delve into that a little bit more and understand that a little bit more. So more to come. My hope is we're gonna propose that we add in CureGN, add Neptune with Sangeeta and the work that's being done here, think about H3 Africa, and sort of combine all those groups and then take a look at the genetics with the drug and then hopefully see if we can tease out a difference.
Thank you. If you have a moment, there's one more question.
Mm-hmm.
Would you like to ask your question?
Yeah. Thank you. It's really interesting. I'm a neurologist, but I think we in pediatrics, we all struggle with the problem of small and heterogeneous populations and lots of different drugs to choose from. So I wanted to ask you a little bit about the trial emulation concept, and I've been trying to wrap my head around this for a while, and how to implement this. And can you tell us a little bit about the journey of implementing these types of studies? How do you decide what data to gather? I know you have 2 minutes.
Yeah, so that's a good question. Yeah. So what Cal had the benefit of was that I had established a cohort study almost 10 years ago where we've been collecting data in a pretty standard way all throughout. So that we collected data, their baseline information. We also had self-reported questionnaires that were done. And so now over a decade, he's got data that can actually go back and use a lot of this information for the trial emulation. We then did it also in the CureGN cohort, where it's another collaborative study, observational study across North America. And what I think, again, is we need to continue to build these kind of open cohorts that we get data from, and we actually plan them accordingly. And that gives us the sample size that you can get, and then you're able to study it over time. You have to plan, though, quite well and prospectively. And there are some variables that we've dropped over time that we haven't seen that they really had that much of a benefit. And examples are, a lot of those are some of the quality of life measures, and they didn't really have too much of a difference for us, but there were a lot of work for patients and families. So we dropped a couple of them over time, and we haven't included those. The thing that I would say is that at an individual institution, you should think about it almost like a learning health system model, that there are things that you can learn also within your own population. And what I think we should think about in pediatrics is almost think about setting up our clinics like a platform where we are, because you're standardized within an electronic medical record. And what can you do to standardize the data collection and the study population from the medical record, as well as potentially from patients and getting consent from them to potentially get biomarkers. But then what you're doing is measuring their outcomes and thinking about it almost from a drug perspective. What are the side effects? what are the adverse events, and what are you going to monitor, and how are you going to decide like time zero? Like what's the information that you need in order to make sure you could emulate a clinical trial? And so what's very interesting is lots of studies are done on genetics and nephrotic syndrome, but they're only done as a cross-sectional one-time data collection. None of it's longitudinal. And none of it has dates. And so because I think about it from an epidemiological perspective, there are dates with every relapse, there are dates that we have when drugs start, there are dates when the drug ends. And so if you have those kind of things done in a standardized way, even if your clinical practice is 20 different providers, if you guys can agree to one way of collecting that information for your electronic medical record, you've effectively set up almost like a platform trial. And then you're ready to use the observational data. And then ultimately, the hope is you're ready to move to a clinical trial. So I hope that answers the question.
That is awesome. Thank you.
Thank you so much. I appreciate your time in this wonderful talk. And I'd like to invite everyone to please come tomorrow to Fellow in Residence Research Day to hear our Fellows in Residence research. And Dr. Parikh will also be speaking there. And you can get your questions answered as well after that. Thank you so much. And I look forward to seeing you tomorrow.
Thanks so much. Take care. Bye.
Thanks,
Bye.
everybody.